Thank you, Lizzie. I'm going to move on from what Lizzie was saying to talk about some of the outcomes we received from the data collection, discuss how we analysed them, and then have applied them both to the AiBle project and to others. So, of course, the main purpose of the EMG data collection was for the robot design in the EMG mode. But as the robot development is still ongoing, I'm going to focus on some of those other data applications a little bit more. Next slide, please. So during the data collection, Hobbs used a recording sheet like you can see on the screen here, where we recorded how many of the 3 reps of each movement a patient completed, along with whether or not they needed assistance for that movement. So here you can see that there are some movements that where a participant was able to complete all 3 reps independently, shown here in yellow. There were some movements the patient couldn't complete at all, which are marked in green. Being linked to the glass, it's likely that this is because the range of extension needed to form a grasp around that object that had a larger diameter was too great for this patient to achieve. There are other movements where the patient could complete all 3 reps, but they needed facilitation, and that's shown in blue. And there are some movements where they needed facilitation and couldn't reach the maximum of 3 reps, which is in purple. And then you can see on the right-hand side here that we also recorded the order in which we completed the movements, and we rotated this between participants. So the reason I'm showing you this is because combining this information with the videos and EMG recordings from Portsmouth Uni gave us a real complete picture and understanding of individual data sets. Next slide, please. So these photos here show you that the team from Portsmouth Uni who helped us collect this EMG data via the sleeve sensors, and you can see the traces here on their laptop screens. And additionally, they also recorded the sessions using a Connect camera, which you can see in the left-hand photo, and there were live video feeds coming through the laptops as well. Next slide, please. So this, if we could just pause on the video for a moment. So I'm going to show you a video here in a second. But what I want to explain is it's very useful and interesting to all parties to collaborate in this way and combine the Hobbs report of facilitation, movement timing and collection with that of the EMG and video footage from the university team. So there's actually 2 videos here which we're going to play. In the first video here, you'll see a small feed on the left-hand side of the patient facilitating the therapist facilitating the patient to complete the movements. And then in the second video, which is on the next slide, the patient can move independently, but hopefully you'll be able to hear the therapist talking them through those movements and providing prompts. So what I'd like you to try and do is to follow the signals on the EMG traces along with the audio that you hear coming from the therapist, and hopefully you'll be able to try and connect the 2. The audio might be slightly faint, so you might need to turn your speakers up if possible, but if we could play the first video now, please. We don't seem to have any sound on that, Sandra, my end. I'm not sure about your end.
Yeah, no, I've got nothing here.
Okay, hang on.
They are a bit tricky when they're embedded into the video, so what we might have to do is just come out. We have to do a separate thing on WebEx, and then we'll go back in. So the change of technology, everyone.
Okay, here we go.
Right. Okay, yeah, same again. 3 fingers. Okay, lift. Good. Okay, and then there's a second video on the next slide.
Did you hear it that time?
Yes, we could hear that.
Okay.
Yeah, just a little bit faint, so just maybe turn up your volume, Sandra.
Lift, place, and back. Reach, lift, place,
back to the start. Reach, lift, place, and back. Right. Okay, and again for me, reaching forwards, lifting, putting that down, and back to the start. Reaching forwards, lifting, down, and back to the start.
Lovely, thank you. If we can go on to the next slide, please. Okay, so hopefully from that you can understand how having the combination of the visual EMG, the video, the therapist prompting, all of that combined can really help the picture for the Portsmouth Uni team when they come to analyse that data. But what I'd also like to reflect on is how this combined approach also benefited Hobbs therapists and patients. So for the therapist, when we look at these EMG traces, we don't necessarily understand exactly what every trace means, but we do get some real-time confirmation of whether or not a patient is generating activity. With support from the uni researchers, we were able to identify whether this is the appropriate and expected activity for normal movement, or whether the patient was using compensations. It also allowed us to identify tonal patterns, including resting tones. So I know the first video was very faint, and I think when these slides are emailed out, you may be able to give it another listen and hear a bit more clearly. But there's a point in that first video where I asked the patient to breathe, and this encouraged her to stop and relax, and you can see the EMG trace reducing before she then continues the movement. And this allowed us to see as therapists that her increased tone had settled before she commenced the next movement. For some patients, facilitation, whether that be physical handling or verbal prompting, can increase activity levels. And immediate EMG feedback such as this was also we could also use it as a comparison to see whether these treatment strategies were appropriate for those individuals. And then for the participants, when we showed them the EMG signals during their movements, they were really positive about getting immediate feedback on their activity levels. And with explanation of what those signals showed and meant, they could understand more about what they were moving. This wasn't part of the trial, but the experience of data collection really highlighted how effective an adjunct this can be to our usual therapy feedback and modulation methods. And within the trial, it also increased participant understanding and therefore their satisfaction of taking part. Next slide, please. So although I've just said that handling is a method of increasing a patient's activity, and it's certainly a very commonplace technique within neurological therapy, it did cause us a few problems during the EMG data collection. So you can see in this photo that the therapist's hands are very close to and at times touching the EMG sleeve, and this created quite a lot of noise in the EMG data collection. So as therapists, we then had to learn to adjust and reduce our handling where possible in order to generate a more useful signal. And this meant finding a balance between our therapy emphasis on normal movement and task completion versus the data collection emphasis on recording true signals. And this is something, as we worked with the university team for longer, we were better able to do to find a good balance. Next slide, please. Midway through our data collection, a question arose as to whether or not all of the patients would be able to trigger an EMG-driven robot. And this was due to some traces being unclear in data collection, hindered by noise, potentially by that handling, as I've just shown, or just generally proving difficult to analyse. So we wondered whether this was more problematic in severely impaired individuals. And we further hypothesised that therefore the severely impaired individuals who had difficulty generating EMG signals may also have difficulty triggering the final robot. And we decided we needed to explore this further. So an analysis was completed to compare the quality of signals generated with the fugal Meyer scores of participants. At the point of analysis, the first 13 data sets had been collected. Apologies, I've just got noise from a printer. I'm going to try and stop it for you. Okay, hopefully that's done it. So the quality of the EMG data was determined by the Portsmouth Uni team using the movement reaching from an object in midplane. The reason we chose this movement is because it's commonly used in rehab. Data may be different for other movements, but this was only a short interim analysis. So we used fugal Meyer scores that were collected and stratified by Hobbs Rehab staff and explored this alongside the EMG signals. So Fugl-Meyer scores for these patients were wide-ranging, from 6 to 63 out of 66 for upper limb motor function, and 45 to 119 out of 126 for their total upper limb Fugl-Meyer. So this was quite a wide-ranging and thorough data set for us to analyse and explore. Next slide, please. Although it was quite a wide-ranging data set, it was quite a small data set, which was okay, as it was only a preliminary analysis, but there were some difficulties interpreting the data in this way. And as a result, we decided that we couldn't conclude from this that there would be patients definitely unable to trigger or use an EMG robot. So we therefore concluded the patients either yes, they were definitely going to be able to use it, or maybe for their ability to do so. So in a moment, I'm going to run through a few comparison table results from the analysis, but just for your understanding, here's a few of the explanations used. So for participants where it says maybe, a data issue means that either there were unexpected large files of data saving, more time was needed to analyse these files, or the data needed recalibrating at a later date. If it says forearm only, it means we had good forearm data, but arm data wasn't sufficient to be included in the analysis. There are some where there were noisy channels, as we've mentioned, and there's one where it says fatigue limiting. So we had a participant who became tired and had to continue the therapy at a later date. So we didn't feel it was very suitable to draw conclusions from this individual. Next slide, please. So the first analysis shown here, we compared the participants' predicted ability to use EMG with their upper limb motor function score out of 66, and it's ordered in this way on the slide, you can see. So we felt this was the most important analysis to undertake, as the upper limb motor function score is often used to stratify patients in research, as we've already discussed today. So the usual stratification would be less than 20 being severe impairment of the upper limb, 20 to 40 being moderate impairment, and more than 40 being a mild impairment. So stratification was considered important for our own protocol as well. We were wondering whether to use this to determine patients for our own recruitment. So any patterns were very important for us to know. But using this analysis, you can see from the screen here, there was no clear pattern or cut-off point that would predict a patient's ability to use an EMG trigger. Next slide, please. We therefore repeated exactly the same analysis, but removed the patients with data issues to see if that made any difference. But still, there was no pattern between the ability to use the trigger and their Fugl-Meyer upper limb motor function score. Next slide, please. So we moved on to complete a further analysis, this time looking at the total upper limb Fugl-Meyer. And this allowed us to also explore influences of sensation, pain, joint range, and some of those other aspects, as Laura was mentioned earlier, that all impact the ability to use the limb. But still, when we ordered it in this way, there was no connection with their ability to use an EMG trigger. Next slide, please. And then the final analysis that we did, we ordered the data sets via either their yes or maybe ability to use the trigger. And when we did this, we were also then able to look at their MAS of their biceps and wrist flexors to see if there was any pattern around that. But still, we were finding no pattern within these data sets. Next slide, please. So overall, this analysis didn't support our hypothesis that more severely impaired patients wouldn't be able to generate the EMG signals and that they may have difficulty triggering the robot. And in fact, the data didn't demonstrate any pattern at all. So although it's a small data set, and as we said, it's quite a crude and preliminary analysis, there was no clear cutoff point at which EMG signals became more or less reliable. And there was no connection at all between those patients with good EMG data and those without. So what does need to be noted is there's a large number of maybes, and it may be that this analysis was too soon to determine what we were looking for, but it was still very interesting to do, as you'll see on the next slide. So if we move on to the next slide, I say despite the lack of patterns, there was a very interesting data set that we did find. So I'm going to draw your attention particularly to participant number 1. And their EMG data showed that they would definitely be able to trigger and drive an EMG robot. Yet they possessed all of the characteristics that we felt may make it more difficult. So they were facilitated by a therapist, which has a risk of noise interference, as we've said. Their upper limb motor score was 13 out of 66, stratifying them as severely impaired. Their total Fugl-Meyer score was one of the lowest at 61. And with sensory deficit and pain reported, they also had some of those other factors, along with spasticity in their biceps and wrist flexors. Next slide, please. So what does this data set mean? It actually had more influence on our ongoing research than a lot of the others, as it showed that a severely impaired patient does have the potential to use an EMG-triggered robot. It supports the inclusion of a heterogeneous sample of patients in our clinical protocol, and we felt afterwards that we should cover a range of severities of upper limb impairment as we progress through the project. So although this can make research more difficult, especially when looking for statistical significance and some of those problems that we said earlier about RCTs, this is a really useful way of looking for individual variations, especially as we look at descriptive and observational studies and case study designs. So as a result of this, we've decided not to restrict the inclusion and exclusion criteria when it comes to our clinical protocol for the AiBle robot, and we'll look at including all levels of upper limb impairment. Next slide, please. So the data from this EMG testing has also been transferable to other projects within Hobbs Rehab, both in 2021 and projects that we're continuing with this year and beyond. So for example, Hobbs have been working on a project with a company called Neurovert, designing a virtual reality gaming device. And the patient testing of this device required the identification of individuals with specific levels of movement in their wrist and hand. So we were able to review our data set of Fugl-Meyer scores from the AiBle EMG testing and identify patients who would be appropriate for this study too. And then a couple of early stage projects we've also been working on wanted to explore grip strength. And as Lizzie mentioned, we took dynamometer grip strength readings from all participants in the data collection. So we have 30 accurate grip strength readings from which an average can be taken to help develop future projects. So in a clinical and research era where time and funding is always at a premium, this collaborative and transferable approach is an efficient way of utilising resources, not just data, but also the knowledge and experience of clinicians. So in Hobbs Research, we believe in cooperation within research and not competition. And for us as clinicians, it showed us how being involved in one research project opens so many ideas and doors to others. And surely this can only help the future of neurotechnology and rehab. To help coordinate future research projects, we've been prompted to generate a Hobbs Rehab research database. And from this, we can look at generating recruitment pools and data sets to extract from and share as possible in future, obviously dependent on kind of the ownership and the confidentiality behind that information. So this links to the MINT concept, which Helen mentioned at the very beginning of today, through which Hobbs provide clinical consultancy and collaboration packages to multiple neurotechnology companies, working with them on product design, development, research, and clinical education. So our experience in research to date places us at the forefront of clinical involvement in neurotechnology. And please do get in touch after today if you or your company would like to learn more about MINT and this approach that we have. Next slide, please. So finally, to conclude this presentation from myself, Lizzie, and Laura, I just wanted to provide a few key insights and reflections from the team as a whole on our data collection. So firstly, in our design process, you saw how we standardized measurements of a patient's reach and the directions and the objects that they reach to. So on reflection, for impaired individuals, there could be different ways we could set this up in order to maximize their reach. But the inclusion of real-world objects and movements in data collection design was something that worked extremely well. The grips required were meaningful to patients. They understood exactly what was being asked of them. And therefore, we're now using these to build the VR games for the AiBle robot, as they are functional movements which as therapists we prioritise in rehab, and as patients they understand. As I'm sure anyone involved in research is aware, recruitment can be hugely challenging. As Lizzie explained, we did manage to have more patients who could have taken part who did, but we certainly underestimated the time and effort that recruitment can take. But we're now more aware of that, and we have those patients now who've consented to further research contact, both for the clinical protocol for the AiBle project and for future projects, which is really beneficial. Regarding the EMG collection itself, it was clear, as I said, how patients viewing EMG traces in real time was of huge benefit to their movement modulation and ability to recruit their movements appropriately. And it's certainly a feedback technique we could explore further in future. Whilst we had a standardised procedure to follow, we were mindful and had to be of patient fatigue. And as previously mentioned, there needs to be more hands-off to prevent noise reduction and allow for true EMG signals went against some of our more conventional techniques. But there were also patients who generated larger signals when we stopped facilitating. assuming because they had been accepting more of our help than they perhaps needed. And that was also interesting for us to see. From the preliminary analysis that I've discussed, as we said, the data set was too small. But a conclusion that arose just during this analysis and since is often in research, the more data, the better, especially when using AI, as we will be for the AiBle robot, and trying to create strong algorithms. So this has implications in, say, the French team are also conducting EMG data collection to get more data sets, but with a slightly updated system, there's the possibility that we could collect more EMG data in future to strengthen the robot development. And finally, the amount of knowledge, data, experience, patient involvement and immediate overflow into other projects created from this highlights the importance of research networks and databases. And working together through these will allow for more time efficient and coordinated projects in future. And together, this should move rehabilitation robotics forward in a truly meaningful way. Thank you. So next slide, please. That's the end of the presentation from myself and Lizzie and Laura. And if there's any questions, please do so.
Thank you so much, Ali. That was, and Lizzie and Laura, that is absolutely fantastic. There was only one question from Aaron, and that was, is this EMG data publicly accessible?
So my understanding is that at the moment, no, it is not, because the project is still ongoing. And also, as we mentioned, we worked extremely closely with the Portsmouth University team during this, and I imagine that they may well have some ownership over that data. I'm not sure whether it will become publicly available in future. I do believe one of our Portsmouth Uni partners is on the call, and if they wish to add anything to that, then feel free for them to jump in. But yes, my kind of summary of that is no, at the moment it's not, I'm afraid.
Thank you, Ellie. If anybody has, Martina says, for most European projects you're required to make the data available. It's something we're discussed with our lead partner. As we've said, we're partners within the project, but we will certainly post that question, Martina, to the lead partner separately, as I know he's not on the session here today.
I think one of the things will be that the data collection is still ongoing. So because we've just presented that from our experience at Hobbs, but as we said, our colleagues in France are actually still collecting data via the EMG process as we speak. So in a sense, I guess what we've presented you is 50% of the EMG data collection so far. So once the full data set is available from ourselves and from France, that's certainly something that we can talk to the Portsmouth team and find out a definitive answer for moving forwards.